Hello, everyone, and welcome back to week number 4 of our weekly teaching. And this week, we are looking at the topic of movement disorders. Now, this is something that you may know bits about, and some of you might find it a bit daunting because you think, well, I've seen a few people with Parkinson's before, but I don't know much else about the topic. So, we will try and break it down as simply and easy to understand as we possibly can. And to do that, we're going to start off by looking at a little case study. You are working in clinic as one of the elderly care doctors, and a man called Tony, who is 86 years old, comes into the room. The first thing you notice is before he's even started speaking, and that is because Tony seems to be shuffling with his steps across the room to the seat. He also seems a little bit wobbly as he turns around to take his seat. When he starts speaking to you, he says that he is very active and loves getting out and walking his dog on a regular basis. But recently, he has noticed that he has been spilling tea from his cup. And when he's been out walking with his dog, he has felt very close to falling over on a couple of occasions. So try and think, what might you do with Tony? What sort of investigations would you think of doing? And before all that, how would you examine him? What questions would you ask? And what examination would you perform? So we'll come back to Tony just at the end, after we've gone through the 5 big points to do with movement disorders. So, first point. Movement disorders can either cause hyperkinesia or bradykinesia. Now, to break that down, hyperkinesia basically means too much movement, and bradykinesia or akinesia means too little movement or no movement at all. Now, when we're breaking movement disorders down, you can look at hyperkinetic movement disorders, which are things like tics or chorea. You might have heard that term, not the country, but chorea. And that is involuntary movements, which tend to involve the hands, arms, shoulders, and face more commonly. So chorea and tics would tend to describe the jerky hyperkinetic movements, but you can also get hyperkinesia that is not jerky, and that is with things like essential tremor and dystonia. Now, we'll be talking a little bit more about essential tremor in a moment. First of all, let me just flip to the other side and talk about bradykinesia, and that is how we would describe what is going on with people who have Parkinson's disease, for example, where there is a slowness of movement. Over repeated actions of doing the same thing, they tend to get slower, and this can affect them with their daily functioning. Everything just slows down a bit. So, in short, movement disorders can be either hyperkinetic or bradykinetic.
Number 2 is essential tremor is the most common movement disorder in all age groups and affects 1 in 25 people over 40. Essential tremor is an on-action tremor. Most often you'll see it when you're doing your finger-nose test. It'll come on as the person's completing an action, whereas a Parkinsonian tremor would come on at rest and is more like a pill rolling sort of motion. Essential tremor is is an isolated symptom associated with itself, whereas Parkinsonian tremor is part of a more global picture that adds up to create Parkinson's. It's just one of many things.
Point number 3, TRAP. TRAP is a very good way to remember the main symptoms that come on in someone with Parkinson's disease, or tend to come on most commonly. So if we break that down, the T stands for tremor, just as Georgie was mentioning. With Parkinson's, that's a resting tremor normally with a rolling motion of the hands. It tends to be in the hands, often starting on one side before spreading further. The R stands for rigidity, and it's a very characteristic type of rigidity in people with Parkinson's, where when you try and flex and extend their arm at the elbow joint, for example, with somebody who has Parkinson's, you will see that sort of cogwheel motion, where it isn't such a fluid movement as it would be with most other people. A is for akinesia or bradykinesia, as I mentioned a minute ago, where there is that slowing of movement and impairment of power when it comes to voluntary movement. So you will notice that with things generally being slower. They will have a flattened facial expression. They will be slower in their movements when it comes to walking, and they will have that typical shuffling gait that I mentioned about Tony earlier on. And P for postural instability, where their balance just is not what it used to be. And if you do a test such as the Romberg's test to see how they are with their balance, it will tend to be abnormal with patients who have more advanced Parkinson's disease. Now, there are lots of other symptoms that you can see in people with Parkinson's too. Some of those include micrographia, which is quite an interesting one, where the handwriting of somebody with Parkinson's can become a lot smaller and quite messy. Then you have things like the flattened facial expression. You have a reduced arm swing. They can take longer to turn around, more steps when they're trying to turn 180 degrees. Then you can also have things such as constipation, depression, and a soft, lower tone of voice. So, a whole range of symptoms, but the most common ones can be categorized with the word trap.
So, point number four is Parkinson's meds must be given on time every time. Even a 10-minute slip in time might seem so small to us on the wards or in the hospital, but that has a huge impact on the patient. And once that symptom control is gone that the medication provides, it can take us a really long time to get that back for the patient, up to sort of weeks and months. So you have to give them on time. In the community setting, something that patients will often do is set timers to remind them, and at the time that they need to take it or a few minutes before, to make sure they're ready and set up ready for their medications.
And point number 5, when you're assessing people who you suspect might have Parkinson's disease, be wary of other conditions that can mimic Parkinson's, because there are a whole host of them. So if you're thinking back through some of those symptoms I was just saying a moment ago, flattened expression, slower movements, and this could be symptomatic of depression, this could be symptomatic of hypothyroidism, even just normal aging in some people. There are some similar aspects to Lewy body dementia when you put that alongside Parkinson's disease. They could have a different type of movement disorder, such as dystonia that we mentioned earlier. There are a lot of things that it's worth you keeping in mind. Now, there are some tests that can be done. You might hear people talking about doing DAT scans, which are head scans specifically aimed at targeting Parkinson's disease and Lewy body dementia. So they can be helpful tests to do. But in general, if you do a full and thorough Parkinson's exam and get a good history, you should get enough information to have a good idea about which avenue you're going down.
So back to Tony. As he walked into the room, we mentioned about his shuffling gait and that he was a bit slower turning on the spot to sit in his chair. So those are both indicators of that postural instability that we talked about. The spilling tea from his cup is a bit of a sign that there's probably a tremor going on. And then further into our history, we can ask a few more questions. Things like, is he having any trouble sleeping? Does he have any constipation? Any changes in his voice or facial expressions? People saying that he doesn't look as enthused in conversation, even though he probably is. Another thing to ask our patients about is any swallowing issues. Are they coughing on fluids more or having any problems swallowing food? So these are all questions we ask for a lot of things, but these are the things we should look out for. So an example of that in popular culture is Paul Sinner, who's from The Chase. For other resources about Parkinson's, we spotted this really nice webinar by mindthebleep.com, and we'll pop a link in the bottom below. It's about 40 minutes long, but a really nice introduction to Parkinson's and a nice overview for us.
And one other thing that I'll pop in the notes just below this video is the Geeky Medics Parkinson's exam page, which is really well broken down. There are videos and pictures to make it easy to keep in your head. So next time you see a patient coming in with any one of the symptoms that we've mentioned today, you'll have that in mind and think, I know the questions and exams that I'm going to do with this person. We will see you again in a week's time. And then we will be talking about, Georgie?
We're talking about stroke this week.
So thanks so much for watching, and we look forward to seeing you again next time. Bye-bye.